you so much. Well, look, thanks for inviting me to talk. I'm a spine surgeon at Epworth Hospital. Epworth Hospital is Australia's largest spine hospital. We do 5,500 spines a year. I do a tenth of the surgery here. So I hope that gives you some reassurance on my competence and experience. But please make this as interactive as you want, and please ask me any questions as you want. Please ask any questions as you go. I want this to be as interactive as you want and get out of it as much as you can. So please feel free to ask anything. It's interesting in Australia, if you stop people in the street and you said to them, how many hip replacements are done per year? And then if someone said, hey, how many knees are done? You'd think that there was more hips done per knees, but it's not. There's actually more knees done. And there's a third of, if you look at all the hips done in Australia, 1/3 as many spine operations are done. But of those, 80% are thoracolumbar and predominantly lumbar. So 80% of spine surgery is lumbar and 20% is cervical. Spine surgery is terribly cost-benefit positive. What does that mean? Well, if you look at the health benefit of a spine operation, if someone can't walk, or if they can't, if they have disabling back pain or disabling arm pain, brachyalgia, leg pain, sciatica, the cost benefit of that is equivalent to heart surgery. So it's very beneficial to the patient. Now, what about fusion versus arthroplasty? Well, fusion, of course, is bone healing. So if you put screws and rods in spine, that's instrumentation. If you put bone in spine and allow that to harden, fuse, that's a fusion. If you have metalware and bone, that's an instrumented fusion. So there's three very good words that are used that are not used correctly. So instrumentation or fixation is the metalware. Fusion means bone healing, but instrumented fusion means hardware and bone. The indications for fusing would generally be older patients with arthritis in their joints, instability, abnormal movement, more than 3 millimeters movement in the cervical spine, more than 5 millimeters in the lumbar spine, and of course deformity. And you can have a coronal deformity in that plane, or a sagittal deformity. So you got lordosis, kyphosis, or you can get a kyphoscoliosis where you have deformity in the coronal plane and the sagittal plane. Arthroplasty, which is artificial disc. So in Australia, a movable disc like a hip replacement is placed in the lumbar spine. You can have them in the cervical spine. Arthroplasty in Australia, we tend to use the word artificial disc replacement. In the United States, North America, they tend to use the word total disc replacement. So TDR is the same as an ADR. And to get that in, you really need to have generally a disc space that's over 50% of normal. If it is narrowed more than 50%, you tend to do a fusion device where you put what's called a cage in. A cage is a fusion device, bone healing device, and it's fixed. Whereas a arthroplasty, artificial disc or total disc replacement, allows motion. Please ask me any questions as you go. Now, in the cervical region, the neck, as you know, there's 7 cervical vertebrae, 1, 2, 3, 4, 5, 6, 7, and 8 nerves. So that means that the T1 nerve goes above C1, and the C8 nerve goes out below C7. So the C8 nerve goes out between C7 and T1. In the lumbar region, there's 5 vertebrae and 5 nerves. So the L1 nerve root goes out between L1 and 2. So if someone has L1-2 whole narrowing foraminal stenosis, it hits L1. If someone's got L3-4 foraminal stenosis, it hits L3. In contrast, in the cervical region, because there's 8 nerves and 7 vertebrae, if someone's got C5-6 foraminal stenosis, it hits C6. So there's just a difference there in your numbering for cervical versus lumbar. Now, if we look at the cervical region, you can do different operations. So this is the posterior or back of the neck. You can rebore the hole where the nerve goes out. So if you got foraminal hole stenosis narrowing, you can rebore the hole. That's a foraminotomy. If you've got a disc prolapse, where you've got a piece of gristle jamming on the nerve, you can do a microdiscectomy where you remove just the red blob, not the disc. Or you can fuse it. You can put a fusion device in and fuse the cervical spine with a fixed lordotic cave. So if you go anteriorly, generally make an incision in the line of the skin crease. A couple of anatomical markers. The thyroid cartilage is usually C5-6. The cricoid cartilage is usually C6-7. You can fuse it with a anterior cervical discectomy infusion. This one. You can do a artificial disc motion. That's the disc replacement. You can do a combination of both. You can do an artificial disc above and a fusion below. That's the hybrid, but you never do that. You never do a fusion above an artificial disc. That's like building your house on rollers. Or a corpectomy, where if you've got a cancer or fracture, you remove the whole block. So a vertebrectomy, ectomy to remove, and corpectomy are the same. Now, with a posterior foraminotomy, lie the patient prone, face down, make a little midline incision, hold the muscles out of the way. That's the photo on the left. Put the instrumentation in and close it up. Cosmetically, very good. The main problem with the posterior operation is pain. The suboccipital muscles and the cervical posterior muscles hurt. So the main problem with this operation is postoperatively for 2 or 3 days, you need very good analgesia. And the main tablet that really helps is an anti-inflammatory. Now, this is an example of an anterior cervical discectomy infusion. And if you look at the picture on the left and you count down, C2 looks like my thumb. So if you look at the sagittal MRI scan, left side's front, and the right side's the back, you can see that number 2, this prolapse is at 2. If you look at the vertebra, it looks like my thumb, fist with my thumb. 3, 4, 5, 6, 7. This is a C7T1 disc prolapse. So hence, that would hit the C8 vertebra, the C8 nerve root. So between C7 and T1, the C8 nerve root, and of course that would give you finger flexion weakness. And the axial picture this way, picture that way, on the right shows the right-sided disc prolapse. That's a soft tissue prolapse. And of course, when you go into the ring of the MRI, you go in head first. So the patient's head's in the ring, their feet are facing us. Hence, the right arm is the left side of the picture, and the left arm is the right side of the picture. The scar is cosmetically very good. It's a right transverse incision. It's made about 4 centimeters long, described by Smith-Robinson. That's the approach, medial to sternocleidomastoid and lateral inside the esophagus and trachea. And you can see that there's 2 cages there. They normally have a lordotic peak polyether ketone cage, space age plastic, with a attached or integrated MRI compatible titanium plate and screws. So MRI loves titanium. As you know, on the periodic table, calcium's 20, titanium's 22. So MRI is designed for titanium. So it's not like the old stainless steel that had iron in it, and you couldn't put that in a magnetic field. You can have any scan you want with titanium. There's a 3-level procedure. Now, corpectomy, as we talked about, you can see the C2 vertebra that looks like my thumb and fist up. Then C3, C4 is destroyed, and that's where you put the cage. Now, normally put a expandable cage, so it replaces the destroyed vertebra, and then you put a plate over the top. So we've taken out the body of C4, and then you've got the screws from C3 down to 5. An artificial disc, of course, moves, and you want to have a physiological range of motion. So artificial discs or total disc replacement can be unconstrained. When I say unconstrained, they move how they want. The problem with that is that because they have abnormal movement, they can rub and cause facet arthropathy, arthritis in the joints or pain. So the ideal prosthesis is semi-constrained, meaning that it only allows 6 degrees, 6 degrees, 6 degrees. So 6 degrees flexion, 6 degrees extension, 6 degrees rotation, and 6 degrees flexion and extension. And so the best device would be a semi-constrained artificial disc. That's the prosthesis that I use at the moment. That's got a titanium upper plate, titanium lower plate with the keels for stability. A hybrid operation, as we talked about, is the artificial disc above and the fusion device below. Now, with the lumbar region, as I said, 80% of spine surgery is lumbar. You can decompress the nerve. So say if someone had terrible leg pain and they couldn't walk, you can decompress nerves. You can rebore the hole where the nerve goes out, hole opening, foraminotomy. You can do a microdiscectomy, make a little incision and go down and get the piece of gristle off the nerve. Or you can do a laminectomy. And a laminectomy is where you make an incision, hold the muscles out of the way, and change the hourglass, narrowing, back to a drain pipe again. See, the spine, the lumbar region and the cervical are just like a drain pipe. And what you can do is rebore the narrowing, the stenosis, and put that back to normal. Now, fusion, posteriorly, there's different ways to do a fusion. Now, if you take off the facet joint unilaterally on one side to allow a cage to be put in, an interbody cage with screws and rods, that's called a transforaminal lumbar interbody fusion. So if it's done from one side, it's a TLIF, transforaminal lumbar interbody fusion. If it was done from both sides, you take off both facet joints, decompress the nerves, put a new disc in, cage, and held them with screws and rods. That's a PLIF, a posterior lumbar interbody fusion. And if you do an operation at the front of the spine and you want to support it with screws and rods, you can do a keyhole, make little slit incisions and use the computer to put screws in, and that's percutaneous fusion. Now, you can also go from the side. So if you lie a patient, generally I do it, lie them face down, lie them side down, sideways. That's called lateral decubitus position. And you make a little flank incision, separate the oblique muscles, go down retroperitoneal, transpsoas. So there's the psoas muscle, and you go through the psoas muscle, and you can get to the lateral aspect of the spine. And of course, when you go through the psoas muscle, you want it to be very safe. So you use neural monitoring to make sure you don't damage the lumbar plexus. So when you do that, you can go in front of psoas, pre-psoas, or through psoas, which is transpsoas, which is my preferred route. The artificial disc we talked about, of course, this is done through the front. So you make an incision in the front of the abdomen, go retroperitoneal, and remove the disc and slot the new artificial disc in. You can do a lateral disc replacement. Lie the patient again. I lie them left side down, right side up, and do the retroperitoneal transpsoas approach. Remove the disc and put the artificial disc in. So going from the front in the lumbar spine, you can lie them what's called supine. So on their back with their legs spread, and the surgeon stands in between the legs, and then you either remove the damaged disc and put an artificial disc in, the ADR or TDR, or you can put a fusion device as a fixed device. With the hybrid, of course, you can fuse L5S1 and put the artificial disc in 4-5. Now, the hybrid operation really is because the lumbar spine is like a house. The sacrum is the dirt. L5S1 is like the concrete slab your house sits on. L45 is like the ground floor, and then L34 is like your first floor. See how L5S1 doesn't move? The lumbosacral junction doesn't move. So you can fuse 5-1 without loss of motion. Now, what about the algorithm for choosing which operation? So generally, if leg is greater than back pain, decompress nerves, and you can either take the piece of gristle off the nerve, that's a microdiscectomy, relieve the narrowing or stenosis in the back, that's a laminectomy. If the back pain is worse than the leg pain, you can preserve motion with an artificial disc replacement, or you can fuse it with a fixed cage. So generally look at what's more, at the leg or the back pain. So looking at these techniques for you guys to know what they are, with a microdiscectomy, you want to remove the piece of gristle, the nucleus pulposus that is ruptured out from the disc, take that away, free up the nerve, rhizolysis of nerve root, rhizo as in Latin for root. So put a little tube down and then look down the tube and you'll see the prolapse, that's the axial MR top left. And then top right, you'll see the nerve root with the disc prolapse next to it. Open up the disc prolapse, and that's the gristle you remove. So that bottom right picture represents the red blob that we've removed. With, there's two types of lumbar disc prolapse. So if you have a disc prolapse that goes standard backwards and hits the descending nerve root. So say you had a prolapse at L34, that would hit the L4 nerve root. But 5% or 1 in 20 disc prolapses go sideways. And this is a good example of what's called a far lateral outside the spine disc prolapse that's hitting the nerve root that's going out. So say if the disc prolapse was at L34, it would hit the L3 nerve in the foramen. So that's a far lateral microdiscectomy. With a lumbar laminectomy, the best thing I say to patients with a lumbar laminectomy is that your spine is too narrowed, and we're going to lift the ceiling up, widen the walls, make the window a double window and the door a double door. That's the foramen, and give the nerves or the chorda equina space. So what about fusing the spine? You can either go from the front, anterior, side, lateral, or posterior. So from the side, that's the standard anterior lumbar interbody fusion, where you make an incision, go left retro around the peritoneum, approach between the vessels for 5-1. So L5S1 is a lot safer because you operate between the iliac arteries and veins. At L45, it's a lot harder because you've got to mobilize and move those blood vessels to the right to get to the L45 disc. You can do a ALIF, the anterior lumbar interbody fusion, this one that slots in. You can do that from the side. So if you've got a very large patient, a very obese patient, you can lie them left side down, make an incision between the rectus abdominis and the oblique muscles, and dissect obliquely down and replace the disc with a cage. With lateral, of course, we can go trans-psoas, or we can go pre-psoas, meaning before. And that's a very powerful technique for correcting coronal deformity. If someone had a scoliosis, a coronal deformity, you can straighten them up really well with the lateral lumbar interbody fusion. And of course, if you go in front of psoas, the other way is a anterior to psoas, or oblique lumbar interbody fusion. And we've talked about posteriorly, prone positioning with removal of both facet joints. That's the PLIF, posterior lumbar interbody fusion, or one side, which is the TLIF, the transforaminal lumbar interbody fusion. This is a paper that Ralph Mobbs and I wrote in Journal of Spine Surgery. So if you want some examples of the paper and those pictures, its first author was Ralph Mobbs, M-O-B-B-S. And if you can't remember that, just put my name in. I'm one of the co-authors. It's Journal of Spine Surgery. And this is a diagrammatic representation of the operations and approaches to the lumbar spine. You can see there that the difference between going through on the left side of the picture, right side of the spine. If you go through the psoas, it's a lateral lumbar interbody fusion. If you go in front of psoas, it's the OLIF. And you can see that the TLIF is an oblique approach to the lumbar spine, and the PLIF is the straight approach to the lumbar spine. Going anteriorly, if you want to just do L5S1, all you need to do is do a transverse incision, because this is relatively simple to get to, and it's between the vessels. A bigger operation would be approaching 4-5, because you need to mobilize those vessels off the spine and hold them out the way for, say, 3 hours while you're doing the surgery. So cosmetically very well tolerated, and they're dissolvable sutures, skin, middle, deep. They'll dissolve over 12 weeks, so that wound will gradually shrink, fade, and any swelling around will go too. So as I said, the supine positioning, you go retroperitoneal approach. So you make an incision, go over the rectus abdominis, and then go retro around in front of the peritoneum. And then you've got to get to the inside the peritoneum to approach the lumbar discs. Now, this is what the anterior approach looks like. You can either do a little vertical incision at 5-1 or a little transverse incision, go round the oblique muscles, dissect outside the peritoneum, and to get to the retroperitoneal space. And that's the bulging disc anteriorly. That's the annulus. And that's just before I've incised it to remove the prolapse. So you can see with a lumbar disc, if you incise the disc, pull it out, you get the pictures on the left. There's the large prolapse being removed, and there's some extra bits. And there's the lordotic angled peak cage. Now remember the physiological angles of the lumbar spine. So it's 3, 6, 9, 12, 15. The way you remember it is that L5S1 is always 15 degrees. And then you take off 3. So 15, 12, 9, 6, 3. So if someone comes in and says to you, oh, I had this operation on my back and I had a lordotic angled wedge-shaped cage put in at 6 degrees at L4-5, you know that patient's missed out on 6 degrees, because you know that the physiological lordosis of L4-5 is 12 degrees. So 6 degrees is not adequate. With the positioning, it'll be positioning right side down, left side up for that oblique approach to the anterior lumbar spine. That's called the lateral anterior lumbar interbody fusion, where rather than the patient being on their back going straight down, we're going to have the patient on their side, and we're going to go on as an oblique to approach the 3 to L5S1 discs. So as I talked about, you can go through the psoas for a lateral, or you go pre-psoas for a lateral. So let's have a look at, this is a lateral fusion on this side. Make a little skin incision, split the external oblique, internal oblique, transverse abdominis, and with neural monitoring, dissect between the psoas muscle, the picture on the right side, to remove the disc and correct the deformity, usually foraminal stenosis, hole narrowing, or of course deformity in the coronal plane. The incision is very well tolerated. You can see that that incision on the left is about 4 centimeters long, and he's a very happy man. So you've got to be very careful when you do the transpsoas approach. You don't tear the peritoneum. You make the incision through the oblique muscles. You've got to get down through the tummy, but to not cause any problems. So you need to use neural monitoring to come down, and just be sensible and careful. If you get any red readings, meaning that the milliamps are less than 8, green, of course, is greater than 15. So if you get any red readings, it alerts you to possible injury, blockage, some sort of other problem with the nerve root you're trying to decompress. So the cages you can put in, there's 2 types of cages that you can put in the from the side. So this one is positioned left side down, right side up. Remove the disc completely and insert a expandable cage which spans the apophyseal ring. So you want to have the cage going across the vertebra, and you want to expand it to a good height so it restores foraminal stenosis, but you want it on an angle here, usually about 10 degrees off that disc, to restore the curve, the lordosis, and the long cage here restores sagittal balance. And there's a wonderful device called the ELSA, E-L-S-A, which is a lateral cage, the top one, with an attached plate and screws. That's a very good, robust device for what's called adjacent segment disease, wear and tear above a fusion. Now, we've got the PLIF, we've got the TLIF, one-sided, and then we've got a percutaneous techniques where you make little keyhole cuts in the back, put a tube down, and operate through the tube to do your operation. Minimally invasive is a funny word. Everyone goes, oh, is that keyhole? You really want to make the smallest cut you can to minimize complications and to have the best outcome for the patient. It doesn't matter that you make a tiny incision, do a shitty job, and don't make them better. So you want to, when they say minimally invasive, it's a small price to pay for a very good relief. And you don't want to have the incision so small you can't see what you're doing. So you can see here that often we use K wires, little Birchler K wires, to check the level we're in. So you can see here the top picture is where pins are put in the skin for the X-ray marking of the skin incision. Bottom left, you can see there's K wires showing where the retractor is going to be, and you've got the cob, the elevator, in the disc space. Then you put the tube down, and then you do the operation with a cage between the vertebrae. This is a really cool device called a spine mask. You put an adhesive plastic over the spine, and it's got fiducials, light-emitting electrodes here, LEDs, and that will register your skin to the computer system. And it's really good for putting percutaneous screws in where you don't want to decompress and you want to fuse. Discogenic pain is controversial. I use discography. Discography is a technique where you sedate the patient. You've got a screen up. The nurse can talk to the patient, and the radiologist will put some local in the skin and put a little needle down, but he won't tell you which disc it is. and he'll do that and then retest you. So the chance of guessing is 1 in 3 times 1 in 3, which is 1 in 9. So you can see there that the L45 disc looks bad. It's got a lot of wear and tear, and because the disc isn't working anymore, you get white bruising on the bone. That's called modic changes, MODIC. So if someone had short-term bone bruising, they would be white on T1. The bruising would be white on T1, which is the long magnet. And then when the magnet's used shorter and you go, the fluid is black. If the fluid is black, the modic 1 was hot, the modic 2 is just black. That's disc desiccation. That's type 2. But the most common painful area is modic 2, where you have fatty infiltration of the end plates due to injury, and the fat stays there. And of course, always confirm it with a discogram, see if the discogram hurts. So say if you do confirm a painful disc that looks bad, the musculoskeletal physician can put a little wire down and zap the joint to say 80 degrees, and that normally lasts about 12 months. Definitive intervention, of course, would be removing the disc and putting either a fusion device in or an artificial disc, a TDR. Now, this is the lateral artificial disc, where you position the patient left side down, remove the disc, and insert a lateral interbody fusion. When the end plates, they're often made of this alloy combination of cobalt, chromium, and molybdenum. They're, of course, all MRI compatible metals. And then you can spray the surface of the end plates to help them fuse or stick to the bone. So I don't know if you can see that, but it's a roughened core of the titanium that helps the patient heal better and maintain motion. This is a XL TDR, so lateral artificial disc replacement, and 2-level pathology in a police officer. You can see there L34 and L45, and put the artificial disc in, happy man at 6 months, extremely good, going back to work and no analgesia. Artificial disc replacement is usually done supine. So the patient is lying on their back, legs open, and you can make either 2 ways of doing it. You can make a little cut here, or the little cut sideways, go around the spine and get to the artificial disc for the impaction of that disc, and that's in the L45 area. And there's a nice example of an artificial disc right in the midline. And that's the axial or up and down view showing the fusion. Anterior hybrid surgery, as we talked about, was the cage and plate at L5S1, the ALIF, anterior lumbar interbody fusion, and the artificial disc at 4-5. You can only say discogenic pain if it's been confirmed on discography. So if someone comes in and they stick a needle in, they can say then that whatever level it was had discogenic pain. So here's one we use the word symptomatic disc degeneration. The patient's got pain. We haven't done a discogram. The discs look shitty, and this middle disc has got a big annular tear, or that anomaly at L45 alerts you to the fact that they would most likely have pain in the back, aggravated by sitting, because that annular tear hurts. It's worse for sitting. And that's the end of the show. I just wanted to thank my assistants. I've got 3 wonderful assistant surgeons, Nigel Munday, Graham Guttenberg, Tim Hurren, and of course Dean Biddow, my research director, for the help with the talk. So look, I hope that helped, guys, and please ask me anything you want.
Thanks very much, Greg. I know it's a bit confusing. Claire did the introduction and now I'm jumping in for the thank you. But thank you very much for taking time out of your very busy schedule to come and speak to us all. It's wonderful.
Pleasure.
Now, does anyone have any questions? I've been monitoring the chat and we don't seem to have any questions in the chat at the moment. Here we go. Here's one. I was wondering about post-op physio recommendations.
So if it's say if you do a decompression, microdiscectomy, foraminotomy or laminectomy, I usually say to them, it's a 12-week recovery. First 4 weeks is getting over the operation, maintaining a straight back, bending their knees, lying on their left side, right side back, no lifting greater than say 2 or 3 kilos. Weeks 4 to 8, do a third of normal, light stuff. You drive the car. Weeks 8 to 12, half normal activities, and then normal activities from week 12. And with a lumbar fusion, the first 6 weeks is getting over the operation, maintaining a straight back, avoiding bending, twisting activities. Weeks 6 to 12, a third of normal, and weeks 3 months, 12 weeks to 6 months, half normal activities. And the main thing is, from a physical therapy point of view, 3 to 4 equal walks are better than one big one. Don't sit for over half an hour. When you sit, of course, you put 40% more pressure on your back than when you stand. So you want to minimize sitting to 30 minutes each episode. And as I said, go for a walk for 30 minutes, then lie down. But if you're going to sit, don't sit for more than 30. So generally, patients after a lumbar fusion are good at 6 weeks, very good at 3 months, and excellent at 6 months.
Brilliant, thank you. I know here I'm working at the Austin Hospital and we certainly see quite a few back surge patients, so it's always good to get you to answer those questions. It's excellent. And thank you in the chat for answering that as well. Any other questions from anyone? Feel free to unmute yourself and ask a question.
I've got a question, Greg.
Hi.
I guess from a physio point of view, when we're seeing patients who have back pain and might have symptoms like in their legs, for example, when would you recommend us to refer to a surgeon? What level of kind of severity do you think is the best?
I think that's a great question. You think, oh God, when do I do a scan? So look, I'm exactly like you, B. It's B, isn't it? Is that right?
Yeah. Yeah, that's right.
B, I'm exactly like you. You see them, say if someone's got predominantly back pain, say if they have tender facet joints, pain on extension, worse with mechanical pain, standing and walking, relieved by sitting. I tend to say they've got facet pain, and you can try physical therapy. Your expertise way better than me. Anti-inflammatory medications after food. You might try some facet injections to see if you can settle this down with 1 ml of local 1 ml of steroid. If, for instance, they have terrible back pain when they sitting intolerance, it's more likely disc pathology, and you might try an epidural injection. You might try a cortisone injection to bathe the discs. When would you do a scan? Well, an MRI will look at soft things. It will exclude, obviously infection. You want to exclude cancer, fracture, which is better seen on a CT or an X-ray, or neural compression, pressure on the spinal cord or nerve roots. So that's best seen on an MR. A CT looks at bone, and the other one I love is an isotope bone scan, a nuclear medicine scan where they inject radioisotope and you look for hotspots in the lumbar spine to see if that will identify where the pain's coming from. So I suppose, B, if someone's got uncontrolled leg pain, if someone's got neurological deficit, whether they have arm pain and numbness or leg pain and numbness, they need an MR. if someone's got gait disturbance, say if they had gait disturbance plus they had weakness of their hands, they couldn't tie up any buttons, they couldn't hold a knife and fork, that would be an indication for an MRI scan to exclude cord compression. If someone had terrible brachialgia, arm pain, and of course a neurological deficit, then they would need a scan to exclude compression in the neck. And with terrible sciatica, leg pain, with numbness or weakness, you might want to get an MRI scan to exclude a lumbar disc prolapse or hole narrowing, femoral stenosis, for their discomfort. The other one that really gets me is a younger patient, 30 to 45, comes in and they say, hey, I've got this terrible back pain, mid-thoracic, thoracolumbar pain, and it's worse at night. When I lie down, the back pain's terrible. Night pain, always be aware of, because night pain is an indicative of a cancer or any type of tumor, whether it's a benign tumor or a malignant tumor. So I have a low threshold to getting an MRI scan. If I'm worried, if you get that terrible feeling where you think, what's going on, I get an MRI scan to exclude a tumor. Does that help?
Yeah, that helps. I guess it's trying to find that balance, because we've learned a lot about, this study, for example, where they did MRIs of completely healthy patients, and they found, disc pathology in a lot of them, people who were asymptomatic. And then I guess patients might kind of jump onto that if there's something going on in their spine, even though it might not be the cause of their pain. Or so I guess it's finding that balance between not pathologizing people, and also obviously if there's a risk of there actually being a kind of dangerous pathology going on, making sure that it's been identified and kind of actioned.
Yeah, I think you've raised a good point there. If you do have an indication for scan, worsening pain despite physical therapy and appropriate analgesia, development of neurological deficit, increasing numbness or increasing weakness, and you need to get a scan, treat the patient. If the patient's got a big disc prolapse at L2-3, yet they've got right L5 pain, that does not account for why they've got the terrible contralateral right leg pain. So treat the patient, not the scan. I like that. You get a scan, you'll find an abnormality on anyone, but whether the scan and the pathology matches, that's the key.
Thank you.
Great. Any other questions?
Greg, I've just got a quick question. Just kind of going on from Jemima's question about post-surgery physiotherapy, would there be any, I guess, benefit in doing kind of a pre-rehabilitation program prior to surgery?
I think that's a great question. I think that, you guys know way better than me that that if you're in better shape pre-op, you'll make a better recovery post-op. And certainly some of the best studies are on psoas muscle morphology, where if the psoas muscle is in better shape, the patient makes a better recovery. And there is good evidence that if you optimize the patient's physical health pre-op, you'll have a faster recovery. So I think core stability muscle strengthening is really, really helpful. And I think a pre-operative assessment, if possible, would really help a patient's care. So I think it's a great question, and I do agree with that. I think there is a big role for pre-surgery physical therapy.
Beautiful. Thank you for that, Greg.
Hey, Greg, I've got a question as well. You said that often your preferred method is to go through the psoas for certain surgeries. Is there a different post-op orders for surgeries that go through the psoas in terms of hip flexion, limiting that, not exercising the core quite as much, or vice versa?
Yeah, great question. when lateral from the side, when about 2009, a Brazilian surgeon, Luis Pimenta, thought that he could correct coronal deformity with a lateral cage. And the trans-psoas approach was suggested by him. Now, the problem with the psoas muscle, as you know, is that the lumbar plexus runs through it. And the lumbar plexus starts off posteriorly and runs anteriorly. So it goes down and forward. So the lumbar plexus at L1, 2, and 2, 3 are very posterior. As you go lower down the spine, the lumbar plexus becomes more anterior. So at 4, 5 goes across the middle of the disc, hence the highest risk of neural injury. So going through the psoas muscle will hurt hip flexion. So if you go through one of the main hip flexors with a trans-psoas approach, all patients will wake up the next morning with a bit of weakness in their hip flexion, a bit of altered sensation in the thigh, and you do it under nerve monitoring. So you monitor, you put electrodes in the lower limb muscles, the leg muscles, and you watch out for any damage to nerve roots, damage to any of the nerves of the lumbar plexus. So you can get approach-related pain, normally lasts a couple of weeks, with pain in the wound, pain in the back, altered sensation anterior thigh, and some weakness in hip flexion. And then you contrast that to damage. So with the psoas muscle, you've of course got the genitofemoral nerve on the surface. Now, if you damage that, of course you get weakness of the scrotal muscles in a man, gives you a dropped testicle. You can have altered sensation in the labial region with a lady. So that it's the genitofemoral nerve, remember, sensory and motor. So there's a difference between approach-related pain with trans-psoas and deficit. And of course, the worst one you can do, the one we all fear, is damaging the femoral nerve that comes out about L3. So we always get the electrophysiologist to watch out for damage to L3. And you can have a probe, when you've got the tube down, you can have a probe and touch different spots to make sure you haven't got a stretched femoral nerve over the disc space. So really going trans-psoas is damage to the brachial plexus. Got to be careful of the nerves, sensory nerves at that level. And say lumbar disc 3, 4, 4, 5, watch out for the femoral nerve.
Great. Thanks, Greg.
All right, just a couple more minutes left. So any last questions before we wrap up?
Look, I just wanted to thank you guys for giving me the opportunity to talk to you guys. And, you know, with your studies, you know, if you ever get stuck and you need a mate, give me a yell. I'm at Epworth. If you ever, you know, want to see some spine surgery, just ring my rooms and I'll try and accommodate the best you can. We're all a team, you know, we're all here to help people and do the best we can. And the best way of doing that is working as a team. And some of my best mates are physios, and one of my best friends is an osteopath. And I have great relationships because we're trying to do the best we can for a patient. And I refer to you guys as much as you guys refer to me. So, you know, look, good luck with your studies. Good luck with your wonderful career choice. It's very satisfying helping people. And look, if you ever need a mate, you think, oh, shivers, you know, what do I do? Or I need a mate to run something by, give me a yell.
That's a really wonderful offer. Thank you so much, Greg. And, you know, a very big virtual round of applause for you. And thank you for taking the time out of your day. I think that's probably all from us for today.
Well, thanks, guys. Good luck with your studies and congratulations on choosing a great career. All the best.
Thank you. Lots of thank yous coming through the chat now.
See you guys.
Beautiful. Thanks. See you, everyone.
Bye.